A 70-year-old male patient coming with chronic constipation is known to be on laxatives and he has long history of intermittent vomiting with background of schizophrenia and an antipsychotic medication. Patient has abdominal distension and hasn't opened his bowel for a few days now. Initially, we have an X-ray to comment on. Looking at this X-ray, we have a typical sign that is called the coffee bean sign. As you can see here, this is the tinea coli, and this is a very dilated bowel lobe around it. So this is called the coffee bean sign. It's typical for sigmoid volvulus. So the answer, distended haustral loop of colon showing a coffee bean sign and indicates a sigmoid volvulus. What are the risk factors of a sigmoid volvulus? We have many risk factors. It typically happens in old ages with chronic constipation or being bedridden or having low fiber diet with fecal loading. So the basic understanding of that will be due to abnormal fecal loading into the colon, that's one, or a hypermobile colon, or if we have a lobe that is, its apex is fixed to the wall of the colon by adhesions, of the wall of the pelvis by adhesions. There's one more reason that we can explain. So if we have an abnormally hyper or mobile lobe of intestine due to congenital failure of rotation of the small intestine, we can also have abnormally loaded loop of the bowel, which can happen in chronic constipation, and this will typically happen in old ages who are chronically constipated or maybe bedridden or having any neurological disorder that will lead to chronic constipation, such as schizophrenia in this patient and being on antipsychotic medications. The adhesions, and the last one which I didn't mention is a neuromesenteric attachment. What are the complications of having sigmoid volvulus? So obviously the patient will have the classic complications from any sign of bowel obstruction. They might end up with sepsis and significant dehydration, significant electrolyte imbalance, and malnutrition and malabsorption. But most importantly, sigmoid volvulus can be a closed loop bowel obstruction, and this can lead to vascular compromise and causing ischemia in the bowel wall and leading to perforation and even peritonitis, and might lead to significant complications such as sepsis and septic shock as well. So that's the main complications that I would mention: vascular obstruction leading to gangrene and perforation of the bowel loop, which will lead to fecal peritonitis as well. We'll have an ABG to comment on. The reason why we do an ABG, to check on the lactate level, to check on the electrolyte, and to rule out any acidosis. Typically, what we're worried about in a patient with sigmoid volvulus or bowel obstruction is metabolic acidosis due to release of the lactate. So we need to check on the lactate level. And obviously, the electrolyte imbalance as well, specifically the hyperkalemia. So in this patient, we'll have an ABG that will show metabolic alkalosis with respiratory compensation, and it will show these electrolyte imbalance such as hypokalemia, hyponatremia, and hypocalcemia or hypochloremia as well. All right, so how to manage this patient? So if you have a patient with sign of bowel obstruction, they haven't opened their bowel for a few days now, we need to assess them according to the CREST protocol, doing an A to E assessment, most importantly, assessing their abdomen, doing abdominal examination, and also starting resuscitation of them and trying to decompress them as well. So that means we're going to put 2 wide pore cannula and insert an NG tube and put a catheter in, and this will technically drip and suck for bowel obstruction. And then PR examination is an essential part of our assessment, and if we know that this is sigmoid volvulus, we can insert a rigid sigmoidoscope trying to deflate it, and if it's not successful, we can do flexible sigmoidoscopy with a rectal tube, trying to deflate the bowel. Of course, if this has failed as well, the patient will need an urgent laparoscopy or laparotomy, trying to deflate or derotate the sigmoid volvulus and fix it to the wall as well to prevent it from happening again. So how to manage? CREST approach, doing PR examination and abdominal examination, and then we can do rigid sigmoidoscopy to be done and flexible with inserting a rectal tube. Definitive management, like I said, sigmoidoscope with a flatus tube or rectal tube, trying to derotate it. If derotation did not work, we can do laparotomy and a midline incision and trying to derotate it manually. And of course, we need to check for the viability first. We can fix it to the wall, which is called sigmoidopexy, to prevent it from happening again. Okay. Of course, if it was gangrenous, we can do resection and even primary anastomosis or duostoma, such as Hartmann procedure basically, and delayed anastomosis or secondary anastomosis. Okay, so that was sigmoid volvulus in a glance quite quickly. A quite similar scenario, a 68-year-old female patient admitted with abdominal pain, distension, and absolute constipation. The first question is asking how to manage this patient. The way I'm going to answer this in an exam, I'll say I manage this patient according to the CREST protocol. Assessing the airway, making sure it's patent and secure, and starting the patient in oxygen if needed, doing an ABG, chest examination, and then moving to the C. We need to rule out any sort of bleeding, do abdominal examination, starting resuscitation by inserting 2 white bore cannula and getting bloods from the patient as well, and also starting IV fluid. If I'm worried about bowel obstruction or the patient is vomiting, I might insert an NG tube N, and I might also insert a urine catheter to monitor intake and output. The bloods that I'm going to send for this patient going to be FPC, UNE, CRP, LFT, and bone profile, Gruber screen, coagulation profile, and cross-matching if needed. We can also consider a VBG/ABG like I mentioned earlier. Following this, we can move in with the D, measure the random blood glucose and the patient temperature. If I'm worried about sepsis, I will do the sepsis sex protocol for this patient, including giving oxygen, giving fluid, inserting catheter and monitoring urine output, and also taking the blood cultures, most importantly, and measuring the lactate level. Yeah, so my most worry about this patient is bowel obstruction. So the main management would be to decompress by inserting an NG tube N, and also to start resuscitation as soon as possible. So according to CREST protocol, and this is literally just going through the basic things that we just mentioned, but we need to be really quick mentioning that. Where would you manage this patient? So this patient can be managed in HDU, ideally in HDU and not in the ward, because they might get unwell quite quickly, and that will be before preparing to taking them to theater if needed. What investigations will you do? I mentioned the bloods early. We can also get some bedside tests, and that will be doing a digital rectal examination, taking a set of observation, doing an ECG for the patient, maybe a quick bedside ultrasound if needed. If the patient is female in the childbearing period, I can get a pregnancy test, but our patient is a 68-year-old, so I wouldn't worry about pregnancy test. The most important investigation will be a CT abdomen and pelvis with contrast. We're basically looking to rule out any cause of bowel obstruction, specifically malignancy or volvulus or adhesions or hernia. Of course, in my examination as well, I would have looked for any hernia sites to look for obstructed or strangulated hernia. So that will be my investigations, and as a last resort, or after doing all these investigations, I will consider laparoscopy or laparotomy based on the patient condition and of course the investigation findings. So biochemistry and hematology, microbiology, radiology, CT abdomen and pelvis with IV contrast. The patient had hemoglobin of 9 and low MCV. Type of anemia this is microcytic hypochromic anemia. Other investigations to know the cause of the anemia, we can do iron profile. We can also do vitamin B12 and folate as well. How oxygen is being transported in the blood. Oxygen is usually bound to the hemoglobin sites. Like 98% of the oxygen will be bound to hemoglobin, and the rest will be diffuse in blood. What is the structure of hemoglobin? The hemoglobin is formed of 4 units, 2 of them of alpha, and the other 2 are non-alpha, which is mostly beta. And in each unit, there is a central iron molecule, and also this iron molecule is the site of association of oxygen to them. So as we see here, 4 molecules, 2 beta and 2 alpha and 2 non-alpha, and we have an iron in the middle, and this is surrounding the heme group. So the oxygen will basically attach to the heme group just around the iron molecule. Factors affecting the oxygen delivery in the blood. So like I mentioned, 98.5% of the oxygen are being transported through the hemoglobin. So the patient has low hemoglobin such as anemia, there will be decrease in the oxygen delivery. Of course, the patient respiration will play an important role because this is what's responsible for the diffusion of oxygen. So if the patient has any obstructive or restrictive lung disease, might lead to decreased oxygen delivery. 2, if the diffusion of the oxygen from the lung into the blood is reduced, again, that will lead to reduced oxygenation of the tissue. And as an example for that, pulmonary embolism or adult respiratory distress syndrome can lead to decreased oxygenation of the tissue. The patient blood pressure and cardiac output as well might affect that, because obviously we need the blood to deliver to the tissue by having an adequate cardiac output and an adequate blood pressure. That's why if the patient had any kind of shock, whether it's cardiogenic shock or hypovolemic shock, can have decreased oxygen delivery to the tissue, and consequently the definition of shock is the tissue is unable to meet the demand due to decreased blood supply. As we can see here, the cardiac output, the oxygenation or the oxygen saturation, and the hemoglobin concentration. And ideally in an exam setting, we need to answer very shortly. So I think my answer needs to be a little bit short. What are the factors affecting the cardiac output? According to the equation of the cardiac output equals stroke volume and heart rate. So stroke volume equals end diastolic volume minus end systolic volume. To be able to find out the factors, we're going to speak first about the heart rate. So the patient age and the cardiac fitness, the patient body weight can affect, of course, the heart rate as well. And if the patient has any systemic disease, such as hyperthyroidism, the heart rate might be increased, and this will consequently affect the cardiac output. The other side, the stroke volume, which is end diastolic minus end systolic volume, can have multiple factors as well, and that will be the patient posture, the muscle tones in the peripheries, and the venous tones in the peripheries as well, and also the intrathoracic pressure and many other factors, and of course the patient age and fitness as well. So heart rate, autonomic innervation, hormones, fitness level and age, and stroke volume, heart size, fitness level. And of course, the male patients are likely to have more stroke volume than female patients, preload and afterload, which we explained that at the stroke volume. A 23-year-old male patient presented following a road traffic accident with GCS of 15. The patient has vomited 2 times and then suddenly dropped GCS to 8. What's the main finding of the following CT scan? As you can see here, there is a biconvex, hyperdense right temporal lesion with compression in the ventricles, midline shift, and the effacement of sulci consistent with the right epidural hematoma. What are the advantages and disadvantages of a whole body CT in this scenario? Whole body CT can give you an early diagnosis of most of the patient's condition because CT is highly sensitive for bleeding and fractures as well. So in trauma patients, it's the ideal investigation to do. However, on the other side, we're exposing the patient to too much radiation. So ideally, we should examine the patient adequately first and then decide which part of the body will need a CT scan. When to consider CT head for trauma patients, according to NICE guidelines, we have classified this into two sections. In the first hour, we need to consider CT scan if the patient's GCS admission is less than 15, or after 2 hours of admission is less than 13. If the patient has sign of base of a skull fracture or depressed skull fracture, or had any seizure, or more than one attack of vomiting, or any focal neurological deficit as well, would be an indication to get a CT hit immediately or within the first hour. Within the first 8 hours, if the patient had a dangerous mechanism of injury, or old age more than 65, or being on anticoagulant medication, or having any bleeding disorder, or maybe if the patient deteriorated with drop in the GCS within that time, will be another indication to get a CT scan within 8 hours. All right. So based on that, 1 hour, we said GCS less than 13 or 15, and also suspected or depressed skull fracture, or sign of base of a skull fracture, post-traumatic seizure, focal neurological deficit, more than one episode of vomiting. On the other side will be this as well, like we mentioned, but I did not mention more than 30 minutes of retrograde amnesia. What is Cushing reflex? It's a neurological physiological response to increase of the intracranial pressure, which will lead to bradycardia, hypertension, and of course associated with increase the intracranial pressure. So it's a physiological response. Of course, it's mixed vagal and sympathetic response as well. What is lucid interval? It's a temporary improvement in the patient neurological status, specifically in those patients with epidural hematoma, and this will be followed by sudden drop of the GCS. As you can see here, this is temporary drop, improvement in the epidural hematoma patient condition. We're talking here about the neurological condition as explained. Management of patient with epidural hematoma. Ideally, this patient needs to be assessed according to the A to E approach. In A, we need to make sure the airway is patent and secure, consider intubation if they need sedation, or if they're being agitated, or if they're being taken to theater, or if they have any maxillofacial trauma. We need to do a 3-point immobilization or stabilization to the cervical spine until it's cleared. And we'll continue A to E as we always mentioned before. The definitive management will be an escalation to the neurosurgeons to do an evacuation, craniotomy or craniectomy for the epidural hematoma. What are the indications of intubation in general? If the patient needs sedation, let's say patients with traumatic brain injury, increase the intracranial pressure, and they're being agitated, this can further increase the ICP. If the patient's GCS is less than 8 and unable to maintain the airway for whatever the reason is, they will need to be intubated as well. If they have maxillofacial trauma, another indication for intubation as well. If they had seizure with drop in GCS and they need further sedation, that will be indication for intubation. So generally, basic concept, if the patient is unable to maintain their airway or they need to be sedated, intubation will be the right answer. So GCS less than 8, this is inability to maintain an airway. Same thing in here, raise the ICP, we mentioned that, and the fractured mandible and seizure as well. We have a female patient who is 34-week pregnant. She's undergoing an open cholecystectomy for necrotizing cholecystitis. Blood pressure is decreasing, heart rate is increasing, and the operation is taking longer than usual. And she also had an epidural and general anesthesia as well. What are the benefits and risks of this patient undergoing surgery? Of course, the patient is pregnant, and she also had a serious condition of necrotizing cholecystitis that can lead to peritonitis and sepsis, and even intrauterine death and preterm labor. By doing the surgery, there is a good chance that we're saving her all these complications of the serious condition of necrotizing cholecystitis. On the other side, she's pregnant and she's undergoing a major surgery. There is an increased risk of having DVT and pulmonary embolism as well. And also there is a risk of preterm labor and intrauterine death. As you can see, these are the benefits and the risk. We need to inform the obstetric and gynecology team, the general surgery team, the anesthetic and theater team, and post-operatively the HDU team or the ITU team. That will answer our next question. We need to manage this patient in obstetric HDU. The patient blood pressure is decreasing. Can you explain why? She's currently in surgery and in reverse Trendelenburg position, those two things can lead to decreased blood pressure. She might be bleeding or dehydrated or inadequate resuscitation during surgery. She underwent combined anesthesia, which can further decrease the blood pressure. On the other side, she might be septic, and this is part of a septic shock or sepsis in general. She's pregnant, so the uterus might be compressing on the inferior vena cava, preventing the venous drainage and consequently decreasing the cardiac output, and this will decrease the blood pressure. You see here compression of the IVC, reverse Trendelenburg position, and also sepsis, inadequate fluid resuscitation, and increased blood loss. What is preload? Preload is the end diastolic volume. This end diastolic volume is responsible for stretching the heart muscle and consequently increasing the cardiac output according to Frank Starling law. As you can see here, that's the definition. What can be done to improve the preload in this patient? So that we need to understand what are the factors that can affect the preload in the patients first. And that's a different question, which I'm going to answer first. The preload is basically affected by the venous tone in the peripheries. The higher the tone, the higher the venous return, and consequently, the higher the preload. It can also be affected by the muscle pump in the peripheries and the muscle status or the muscle tone. It can also affect by the patient position. So if the patient is in Trendelenburg position, that can increase the venous return, but our patient is in reverse Trendelenburg position. On the other side, the intrathoracic pressure, which is usually decreased by inaspiration, thus inaspiration can increase the venous return. So what can we do for this patient to improve? We can change the position. We can manually displace the uterus to increase the venous return. We can give her some inotropes or start her in fluid as well. I did not mention that one of the other factors that can increase the venous return will be the blood volume, all right? So the intravascular volume. So we can do all these four things to increase the venous return. What is a shock? So it's a metabolic and circulatory collapse due to inadequate tissue perfusion, and it has a significant mortality and morbidity when comparing to sepsis or anything else. So circulatory failure, inadequate organ perfusion, and the organ cannot meet their metabolic rate. The body response to decreased blood pressure will have basically three different types of responses. One is an autonomic response. The body will try to increase the sympathetic tone to compensate that by increasing the venous tone as well, and this will increase the peripheral vascular resistance and consequently can increase the venous return. There is also hormonal response. The body can secrete mineralocorticoid and catecholamines from adrenal medulla. Adrenal medulla, by secreting catecholamines, can lead to vasoconstriction again to the peripheral blood vessel, increasing the peripheral vascular resistance and then the increase in the venous return as well. That's why usually shocked patients will have cold peripheries. We can also have increase in the mineralocorticoid from the adrenal cortex, and mineralocorticoid can lead to increased aldosterone, which will lead to salt and water retention, increasing the intravascular volume and consequently increasing the venous return and the preload, and this will increase the cardiac output. Another response will be a mechano response or baroreceptors. Baroreceptors, these are receptors that are found on the upper end of the carotid sinus, which is basically in the upper end of the common carotid artery, or the lower end of the internal carotid artery, and also present on the aortic arch. These receptors are very responsive to any stretch in the wall. So with arterial dilatation or vasodilation, these receptors will be activated and lead to a stimulation of Herring nerve, and this will lead to again constriction or increasing the sympathetic activity. We have autonomic response, reflexes, which are the baroreceptors or mechanoreceptors, and also hormones such as catecholamines and mineralocorticoid. What are the baroreceptors? I think I explained that, and we mentioned the Herring nerve, which is a branch from the glossopharyngeal nerve. The factors affecting venous return, I think I answered all of this as well. The intrathoracic pressure and the skeletal muscle pump, the posture of the patient, and finally venous return, and here the intrathoracic pressure. So we mentioned during inaspiration, the intrathoracic pressure will decrease. Some devices used in mechanical DVT prophylaxis, these devices are like the pneumatic compression and also the TED stockings. intermittent pneumatic compression device, and also TED stocking, as you can see. A 35-year-old female patient who is known to be an IV drug user and has HCV and HIV as well. Presented with non-healing venous ulcer on the lower limb with inguinal lymphadenopathy as well. What is HCV? It's a hepatitis C virus, which is an RNA virus that typically affects the liver and usually presented by common pathologies in the liver, which can include acute hepatitis, chronic hepatitis, liver cirrhosis, liver failure, and finally hepatocellular carcinoma. I sort of covered the first three questions, as you can see here. So we have the definition of HCV, and it's an RNA virus, and also these are the pathologies that can usually present. What's the pathophysiology for this patient having a leg ulcer? So this patient might have increased the cryoglobulinemia, specifically in HCV, and also we mentioned earlier that she's an IV drug user. If there was injections in the femoral artery, frequent injection in the femoral artery can lead to thrombophlebitis in the lower limb and can even lead to DVT, which can increase the risk of having a venous ulceration if the patient had a previous DVT. Okay. The ulcer was swabbed and showed candida. What are the types of microscopic features of candida? There are multiple different types of candida. There are over than 150 different types. However, there are a few types, which is Candida albicans, Candida tropicalis, and these are honestly the only two that I remember, but there are 6 other common types, which include Tropicalis, Clapperta, Parapsilosis, Krusei, and Lustian. The Candida typically has a sooty hyphae, which is the typical characteristic for the microscopic features of Candida. Patient had inguinal lymphadenopathy. What is the structure of a lymph node? So a lymph node is a capsulated structure that is formed of a cortex that has mainly B cell and the parotid cortex that has T cells and follicles as well. For each lymph node, there will be conduit, which are vascular channels that allow the afferent and the efferent to pass on to the lymph node. Of course, there will be an afferent bringing the blood supply to the lymph node, and the efferent, which is taking the lymph away from the lymph node. So these are the structures very briefly. So each lymph node up to 20 millimeter in diameter, outer cortex containing B cells, and inner paracortex containing T cells, and there is a vascular conduit, which are channels that allow the lymph vessels to enter and leave the lymph node, and the efferent, which is T and B cells, leave via the efferent. And all these structures I mentioned at the beginning that they are capsulated structure, as you can see here. What are the types of necrosis that you know? There are many different types of necrosis. Can include fat necrosis, which typically happen in the breast. There is also liquefactive necrosis, which can happen around the pancreas in acute pancreatitis. Gangrenous necrosis, which typically happen in diabetes, specifically patient with diabetic ulcer. And gangrenous necrosis could be a dry gangrene and also wet gangrene. Wet gangrene happens due to secondary infection over dry gangrene. There are also caseous necrosis, which usually happens in TB. And fibrinoid necrosis, which can happen in a case of malignant hypertension in the wall of the blood vessel. So if we can see the answer, we have coagulative necrosis, liquefactive necrosis, gangrenous necrosis, and also this is how the gangrenous necrosis looks like. Caseous necrosis, fat necrosis, I did not mention saponification, and finally we have fibrinoid necrosis as well. We have a lady who is known to have ulcerative colitis and on surveillance for colonoscopy and is found to have a sigmoid colon lesion. What is ulcerative colitis? It's an inflammatory bowel disease characterized by inflammation of the colon, typically starts from the anal canal and works its way up in the colon but never happens outside the colon, and is also characterized by formation of ulcers. We have a few gross pathology to present. So in these 4 images, in the first one, we have a pancolectomy characterized by presence of colitis or signs of inflammation along the colon with healthy areas in between. So as you can see here, this red area, this is form of colitis, and on the other side colitis as well. And as you can see in the splenic flexure, there is colitis as well. Image B, there is signs of colitis, which is inflammation to the wall with a good line of demarcation between both of them. Here we can have presence of polyps, inflammatory polyps, as you can see here, characteristic for again, ulcerative colitis. The last image, you can see mucosal bridges in between. Again, that's a characteristic of ulcerative colitis. The other one, these are the characteristic of Crohn's disease. As you can see, there is here a structure, that's Crohn's structure. And obviously this part is dilated and inflamed as well. This is the copulostone appearance in Crohn's disease. This is serositis and perforation of the wall of the colon. And these are creeping fat, which is a characteristic of Crohn's disease again. This one, we have inflammation in this specimen with a good line of demarcation between the healthy and the non-healthy part of the colon, characteristic of ulcerative colitis. Clinical presentation of ulcerative colitis, typically a female patient, middle-aged, present with abdominal pain and bloody diarrhea and weight loss. What is tumor necrosis factor? It's one of the acute phase reactants. So it's a cytokine and it characterized to be secreted in acute inflammation. What is the role of tumor necrosis factor in inflammatory bowel disease? It regulates the innate immune response in patients with inflammatory bowel disease to direct the epithelial cells to increase the tight junction permeability, and this will consequently relocate the luminal bacteria into the wall, leading to signs of acute inflammation. As you can see, these are the epithelial cells. Normally, there is a tight junction between all the cells, as you can see here, to prevent any luminal content or bacteria of relocating into the wall and the blood flow. But due to tumor necrosis factor activity in patients with inflammatory bowel disease, this tight junction will become very loose and will lead to a relocation of the bacteria inside the wall and in the blood vessels, leading to signs of inflammation. And this is an abnormal mucosal reaction, as you can see. We have a few drugs that antagonizes this medication, and these drugs are adalimumab, cetuximab, and infliximab as well. The mechanism of action of these drugs, it's a monoclonal antibody inhibitors. So basically, they inhibit the monoclonal IgG1. Why are they used in treatment of ulcerative colitis? They are usually used in patients with extra colonic manifestations or those patients who are refractory to the steroid use. So in this image, I'm gonna close the question again, but we need to talk about DO criteria for colon cancer and the TNM staging. So DO criteria characterized by 4 stages, from 1 to 4. Type 4 characterized by distant metastasis, and type 1 characterized by a cancer in the wall. Type 2 through the wall, so basically it's come outside the wall, and type 3 characterized by inclusion of the lymph nodes. The TNM staging, I'll start with M. We have M0, there is no distant metastasis, and M1 characterized by distant metastasis. N, we have N1, less than 3 lymph nodes involvement, and N2, more than 3 lymph nodes, so basically from 4 above. We have the T staging, you have T1, and this is basically including the not beyond the submucosa, and T2 is beyond the submucosa but not outside the musculosa, and T3 it's outside the musculosa, and T4 when it's associated with distant metastasis. So T1 not beyond submucosa, T2 not beyond muscularis mucosa, and T3 beyond muscularis mucosa, and T4 beyond all of this, which include lymph nodes and distant metastasis. The treatment for ulcerative colitis, we can try medical treatment at the beginning. However, the main treatment will be colectomy or pancolectomy. What is adenoma-carcinoma sequence in patients with ulcerative colitis? It's a stepwise of accumulation of tumor suppressor gene and mutation of onctions, characterized by presence of mutation of APC gene and also KRAS gene, and finally the TP53 gene mutation as well. You can see here it's a stepwise accumulation of mutations of the oncogene and tumor suppressor gene. 3 genes, as you can see: APC gene mutation and KRAS mutation and inactivation of TP53. Proto-oncogene and tumor suppressor gene mechanism. We're going to start by the definition of proto-oncogenes. They are normal cellular response, which is responsible for proliferation of cells, but this will maintain the cell differentiation from the tissue of origin. However, oncogene is a mutated or overexpressed proto-oncogene at which the cells has lost dependence from the tissue of origin, leading to overexpression of mutated cells. On the other side, the tumor suppressor gene is again a normal gene, and the mutation in it is bad. So the tumor suppressor gene is basically responsible for activation of apoptosis to kill the mutated cells with abnormal DNA. They act as the gatekeeper, so they identify the abnormal grown cells and start changing them into apoptosis to die. And they are also responsible for DNA repair. Proto-oncogenes, as you can see here, normal cell response for cell proliferation. But in this type, we're maintaining the differentiation of the cells. Oncogenes, we lost differentiation because they are mutated proto-oncogenes or overexpressed proto-oncogenes. Tumor suppressor gene, P53, they are the gatekeepers. They do DNA repair and activate apoptosis. What is the function of KRAS? This activates the MAPK pathway, and I'm not going into details of that. It's quite complex. What is the function of TP53? We mentioned it's the gatekeepers, so they identify the abnormally grown cells with abnormal DNA and turn them into apoptosis or try to repair their DNA. And if the repair has failed, the apoptosis will be activated through this gene. Okay, as you can see here, they can also cause growth arrest and DNA repair and apoptosis as well, or cell death. What is the function of APC gene? It encodes factors that activate the WNT pathway in the colonic epithelial cells. Finally, we need to compare between ulcerative colitis and Crohn's disease. So ulcerative colitis, it's a colonic inflammation or one of the inflammatory bowel disease that exclusively affect the colon only, characterized by ulcer formation and sometimes formation of polyps as well. It doesn't invade the submucosa, so consequently it doesn't lead to perforation of bowel, characterized by bloody diarrhea and sometimes extracolonic manifestations, and usually associated with primary sclerosing cholangitis in a female middle-aged patient. Smoking usually protects against ulcerative colitis. On the other side, Crohn's disease, it's an inflammatory bowel disease that can affect the patient from mouth to anus, so it can happen anywhere in the tract. It's a transluminal inflammation, which means it can lead to bowel perforation because it invades all the wall of the colon. It's also associated by escape lesions and formation of some abscess in the wall of the cells. Smoking can exacerbate the condition, and patients are advised to stop smoking in Crohn's disease. So this is mucosa and submucosa, but it's not beyond the submucosa. This is full thickness, and again, mouth to anus in Crohn's. On the other side, it's mainly in the rectum and colon. Patient characterized by bloody diarrhea and ulcerative colitis, no bloody diarrhea in Crohn's, crypt abscess in ulcerative colitis, lymphoid aggregates here. This one characterized by pseudopolyps formation and loss of histra, so the lead pipe appearance on a barium enema. On the other side, this is a coprolistine appearance characterized by stricture, toxic megacolon ulcerative colitis. We talked about primary sclerosing cholangitis and ulcerative colitis, but in Crohn's can be associated with ankylosing spondylitis. The smoking protect against ulcerative colitis, but exacerbate Crohn's disease. This is in a nutshell how to revise the ulcerative colitis and Crohn's disease.